Welcome to the Owens Recovery Science Podcast, where we dive deep into all things blood flow restriction training. I'm your show host, Johnny Owens, and whether you're a clinician, researcher, or athlete, you've come to the right place. Each episode, we break down the latest research, interview leading experts, and translate complex science into practical applications. We're here to bridge the gap between laboratory findings and real-world implementation. Welcome to another Owens Recovery Science Podcast. I'm your host, Johnny Owens, with my co-host, Kyle Kimbrell. And it's a rough day today. Spurs had a bad night last night, but I'm going to represent my Spurs gear no matter what. I'm going to jump right into this podcast because we have someone that I am so excited to talk to about everything he is doing. It's Dr. Brian Feeley, who is the chief of sports medicine and shoulder surgery at University of California, San Francisco. He's a San Francisco Giants team doc. He's published over 300 papers. And if he wasn't busy enough with that, he just throws on running a really, really badass lab over there. It's the Muscle Injury and Translational Orthopedics Lab, which sets up the perfect abbreviation, which is Mito, which we're going to be talking quite a bit about mitochondria today. So I didn't catch that until I was just looking at the bio earlier.
Yeah.
He won the Kappa Delta Award last year with my good buddy, Matt Provencher as well, I believe,
Nice.
which is basically the most prestigious award you can win in orthopedics for your contribution, your research arc. Avid surfer, big family man. He's the kind of guy I freaking hate, Kyle, because he makes me question what the hell I'm doing with my life.
I'm like the most jealous of is I saw Little League Coach of the Year.
Well, yeah,
I'm jealous of that one.
Yeah.
That's the one that got me.
Brian, welcome. Thanks so much for coming on.
Yeah, thanks for having me. Sorry about the result last night. I still have Spurs in 5 or Spurs in 6. So
Nice.
I'm going what they were just exhausted from playing OKC and watching SGA flop the whole time.
Yeah. I think we had a little bit of a harder run. So yeah, I appreciate it. So anything I left out that you want to chime in on your bio or background?
No, that's more than enough. Fun fact about the Kappa Delta is the Kappa Delta sorority, which originally sponsored it. I was the last recipient because they decided they were no longer going to sponsor orthopedic research. So I will be one of the few that won it twice and the last person that will ever have been awarded that.
Come on, Kappa Delta. I'll reach out to my daughter's sorority and see if they'll step up.
Sure.
So if you can kind of tell us, obviously orthopedic surgeon, and that's a pretty straightforward path, even though it can be a hard path. But what got your interest in setting up the Mito lab? Were you always wanting to be a researcher?
Yeah. So I started doing some sort of research as early as freshman year in college, and I'd even done a few other things in high school. So my interest has always been in basic science and translational research. So I had started in a stroke lab. I spent a very brief amount of time working with fruit flies, which was horrible because my experience was basically sorting flies on an ether panel. So you basically just work until you feel like you have a really bad headache. Did some really fun work. Well, it wasn't really fun work, but I thought it was really interesting in transcriptional regulation of cancer. And then in med school, I started working with a guy named Bobby Robbins, who is a cardiac transplant surgeon at Stanford. And we were interested in different mechanisms of improving how hearts would last longer through gene therapy and other treatments. And that really opened my eyes to the idea of ischemia-reperfusion injury.
Mhm.
One, and two, just how much fun it can be if you have a really good team around you. And then when I went to residency, I worked with Jay Lieberman, who's now chair at USC, and we worked on some gene therapy experiments. And I got to the point where I realized gene therapy is probably not the end all and be all, but I really liked the basic science of muscle. So when I was deciding what we wanted to study when I started my lab back in 2008 to 2010, I really was interested in rotator cuffs because rotator cuffs are kind of fascinating. You get most injuries. So let's say you break a bone, we fix a bone. Let's say you tear your Achilles, we fix your Achilles. If you get a rotator cuff tear, 9 out of 10 times we say, hey, you know what? Let's just see how you do. So it gives us really nice incubator to see what happens as people get older. We all get older. And your muscle slowly gets worse over time because it's not attached to its bone. So I thought this was a really nice biological model that was also very relevant because we knew at this time um, we have muscle that is going to get a little bit smaller. And then at that time, we understood that we got fat that infiltrated in. And that I thought was really, really interesting because the way they described it as fatty infiltration makes no sense.
Mhm.
Fat doesn't move very much, it kind of just accumulates. But there were these studies in sheep models that showed the way the angle of the muscle changed may allow fat to walk in. And I was like, well, that's kind of stupid. That's not probably not what happened. So I thought we had a really good mechanism to study. Nobody else really studying it. I didn't want to study cartilage because everybody else seemed to be studying cartilage and tendon. And then I was partnered with Shuwei Liu, who had done some ischemia and reperfusion injury in kidney, but was inherently interested in muscle. And we've worked together for the last, I think we had our 15th year anniversary last fall. So it was probably my longest professional relationship. And we've worked really well together and synergistically to grow a lab that was originally 2 to 3 people to now about 20, depending on where we are in the summer, almost up to 30 people.
So I think most people still obviously think it's a fatty infiltration. Can you explain what's actually happening?
Sure. So it is in a sense, and what we've found, and this was piggybacks off this group in Japan who looked at these progenitor cells called fibro-adipogenic, which they discovered in 2009, 2010. And the idea is that within muscle, there are these helper progenitor cells that, given the right context, will help muscle repair, but in other contexts, will turn either into scar tissue or into fat. So, if, for instance, you have a nerve injury where the muscle often turns into fat, these fibroadipoprogenitors or FAPs will differentiate into an adipogenic or fat lineage. And we can see that pretty easily in muscle. So we started looking at these cells in first a mouse model of injury. So we essentially create a rotator cuff injury and then just track what happens to FAPs with reporter mice because they express some unique factors on their surface. So we can basically just look over time and see, are there more after a rotator cuff? There are. Do they co-localize to where the fat is? They do. So that suggests that these cells are responsible for fatty infiltration. We can then knock them out in mice, so that you just have mice that no longer have them, and then we didn't see any fatty infiltration. And then to prove that mice are like humans, because we're about 97% similar, we took tiny, tiny muscle samples about the size of 2 to 3 grains of rice at the time of rotator cuff surgery, and essentially did the same thing. We tagged these cells, showed that they were more where there was fat, and that they co-localized to where there was fatty infiltration. Obviously, we can't um, genetically knock out these cells in humans, but we feel like that's enough correlative evidence, and there's been plenty of other labs that have followed up on that. So we think that these cells don't infiltrate, but they get a different set of signals from the tendon being unloaded, the inflammation around, and probably subtle changes in innervation to change their internal signal to go from kind of a resting progenitor cell into an adipogenic cell. And then once those cells start becoming adipogenic and they release other factors, that's your muscle signal to say, well, I'm at rest. I'm not really doing anything. So I'm just going to store energy just in case I might be needed in the future. But the problem is once you get enough fat within the muscle and the muscle shrinks enough, our bodies just don't really recover from that.
And that's, man, it was so smart to go down this road, because you can look at this and you say, well, these guys are kind of like a villain, but actually they can be something very valuable. And so can you talk about their ability to transfer mitochondria and how they could be useful in your models?
Yeah. So one of the things that we found was that and I credit a lot of this to Mike Davies, who was a med student with us, and he was a resident with us. We sent him off to HSS, and then we brought him back. And one of the things that we had seen was that if given certain drugs, these FAPs would turn into something that looked like beige fat. So there's different types of fat. There's white fat, which we all have around our midsection. That's kind of our insulation and energy storage. There's brown fat, which is what rodents have to hibernate. And then there's beige fat, which is kind of a unique in between, where it has some fat, but it tends to also have a lot of factors within it that are for energy storage. So it's not quite the typical fat. We find it in very small pockets. But what's unique to these cells is that they tend to have a lot of mitochondria, one. And two, they express different proteins, so we're able to track them over time. And what we had found was through a few different studies, when we gave pharmacologic agents that stimulate down certain pathways, you get an uptick in these beige fat-like cells or pro-myogenic cells because they express a bunch of things that help muscle grow. They also seem to be collecting more mitochondria, but they didn't seem to be very active overall. So they seem to be in this kind of resting state. So what we have then are these cells that are turning into fat. They can go down different fat lineages, but then they seem to accumulate extra mitochondria, which we all remember from middle school and high school are the powerhouse of the cell. So that doesn't really make sense to us. So what we're really interested in was, why are these cells that aren't really doing that much other than kind of holding energy,
Yeah.
why would they have all these extra mitochondria? And it turns out that through different stimuli, and this has become a much more complicated story than we were originally hoping, but mostly in a good way. With given these stimuli and in certain circumstances, particularly with ischemia and reperfusion, it seems that these FAPs will then transfer their mitochondria to other cells, particularly myocytes and other progenitor cells, like your satellite cells, which make your healthy muscle. So what that means is that if you give muscle a certain stimulus when it's trying to recover, these FAPs not only can secrete other factors that help muscle recovery, but they can donate the mitochondria that they're not using into these other cells that need the more energy to grow and proliferate and divide. And the mitochondrial transfer part was all largely Mike Davies' idea, and he's done a lot of really elegant studies on this, but this comes from studies that show that this how stem cells rescue other stem cells, whether it's in the brain or within other developing and repairing tissue.
How do you do a mitochondrial transfer? You
So,
actually injected, right?
mm, no, our cells are very adept at it. So there's 3 different mechanisms that cells will transfer mitochondria from one cell to another. First, they will create little tubes that will go from one cell to another. Second, they will put it in little like garbage packaging. So I like to think of it as you're throwing out your trash basically, but in a very directed way. So more like recycling, not going to the regular trash bin. So they'll package them in little exosomes and release them to other cells, or they will open directly from one cell to another. So kind of just like opening your car window and accepting something from the drive-thru. So all these mechanisms are probably in play at different times, and depending on which cell populations are doing it. And part of the wonderful things about our body is we have a lot of redundancy. So you can knock out one of these systems and another system will kind of overtake and be the dominant pathway. So anytime we think that something is vital, there's a little bit of redundancy in the system. So probably this mitochondrial transfer is fairly vital for how cells communicate and transfer energy from one source to another.
And so the ischemia-reperfusion model is what led you down where I want to go next is your mouse BFR study. And so was your thinking that if we had some ischemia, and this is very interesting because it would be proximal to the cuff, which is the biggest question we always get is, how does this happen proximal? And maybe some metabolic stress on the muscle as a signal that would turn on this transfer?
Yeah. So both Shuei and I had done some work, like we talked about, in ischemia and reperfusion injury. And we know that anytime you get ischemia, or cut off blood supply, and then reperfuse or get that blood supply back to muscle, kidney, cardiac tissue, it's this insult that can, and with the right amount of stimulus, so a little bit of ischemia and reperfusion, which is very similar to BFR, will stimulate a variety of different pathways that we would consider regenerative or at least reparative. If you give too much and you just get ischemia, you eventually tip that scale into cell death and necrosis, and essentially the same as cutting off any other blood supply for more than 5 to 6 hours. So we had each done these studies looking at ischemia and reperfusion in other organs. And then we had done a preconditioning study where we had done a little bit of essentially early BFR, where we put a tourniquet on and saw that we saw an increase in these FAPs within muscle. And they seemed to secrete factors that were pro-myogenic. So we had this idea of, well, if that was just one study looking at a pretty simplistic method of conditioning these cells so we get more cells within muscle, what if we did it in a more formal way, very similar to how we were seeing BFR used in clinic? And because mitochondria are so sensitive to ischemia and reperfusion, we thought it would be interesting to do this study and ask the question whether or not this mitochondrial transfer phenomenon was at least partially or largely responsible for some of the mechanisms we see of how BFR may work within muscle.
Can you go into that mouse study?
Sure. So what we did is we took mice that are genetically altered. So every FAP has mitochondria in them that essentially are green. So we can track where the mitochondria go. So if you have FAPs with mitochondria, every place that we stain afterwards, so when we do histology, if we see green light up, that means those are mitochondria that came from FAPs and went someplace else. So our first question, because we see some variable efficacy in how well BFR works in patients, was, well, what is the ideal dose? And since we are working with mice and not people, we had a fairly rudimentary rubber band that was tight but not too tight. And then we asked basically once a week, twice a week, 3 times a week. And what we found was 3 times a week, we had a much, much better effect. And we saw that in two ways. One, the muscle recovery was better. And then second, we saw mitochondrial transfer much more consistently. So when we did it once a week, we didn't really see much mitochondrial transfer up to 7 days. When we did it consistently every second to third day, we saw consistent mitochondrial transfer. So from that, we thought, okay, this needs to be happening probably a little bit more frequently than once a week, or what ends up happening once every couple weeks when patients go to physical therapy. And then we wanted to ask, well, what happens when we do this in a rotator cuff injury? Can we promote muscle regeneration through this mitochondrial transfer? So we basically give the mice rotator cuff injury and then did this BFR treatment over a course of 6 weeks. And what we found was that even though the tourniquet is distal to where the rotator cuff is by, in mice about 5 to 7 millimeters, there was consistent there was consistent mitochondrial transfer, and that directly correlated with better muscle quality and more strength and function within the mice. So even though it's distal, we think that local ischemia and reperfusion allows the muscle distally, so far away from the tourniquet, to get injured, stimulate muscle proximally, wherever there's an injury state, to release mitochondria from FAPs to other cells to promote regeneration.
I love the paper because the graphics are badass. Because seeing those little green mitochondria, it's so visual because you did it on healthy mice, and I think after day one, you see the baseline muscle, and there's not a lot of green, and then after that day one of BFR, it's like Green Lantern image. It's all over the place. And the same thing when you did it in the rotator cuff tear model. Just seeing all that green, you can visualize that transfer. And then what was really cool was showing the little mice being able to walk, their little paw prints. So they obviously were having less pain and more function. So can you speak on that, and also like maybe even less fibrosis? Because that's something we really have been talking a lot about is muscle fibrosis.
Yeah. So I think one of the things that's lost in patient populations is that we know what happens to muscle based on how much fat content and how big or how much water content there is in the muscle and how big it is in muscle, or how big your muscle is. So when you think about what we look for in MRI, we can see size of muscle or the amount of muscle loss or muscle atrophy. And then we can see the amount of water content, which depending on the sequence is largely the amount of fat. We can't see fibrosis with typical T1 and T2 imaging. So we don't get a good sense of how much scarring there is between the muscles, but we know from our mouse studies and from the occasional times we've really looked for fibrosis, wherever we see fat, we see fibrotic tissue too. So even if we talk a lot about fatty infiltration, we know that part and parcel of that is some of these FAPs are also creating more scar tissue as the muscle gets smaller, and particularly the more distal the injury is. So you go from kind of your trunk where there's a lot of adipose differentiation to your extremities, there's a lot more scar differentiation. So any effect that we think that we have on FAPs is going to be bimodal, meaning we are going to not only decrease the amount of fat degeneration, but also the amount of scar production within the muscle. And that's important because even if we can't measure it, we think that that probably has some level of, or we can't measure it on MRI, that is going to have some level of clinical effect in terms of how distensible your muscle is. How much are you going to be able to flex? And even if your muscle's gotten bigger, if there's scar tissue between each fiber, it might not be as effective. So when we looked at our histology, we found that this, from our standpoint, not surprisingly, if we are decreasing the amount of fat through this effect, because these FAPs are going back to their promyogenic condition, they're also going to decrease the amount of fibrosis. And then in terms of function, it's really hard to ask mice, how are you feeling?
Yeah.
And yep, I like to consider the different ways we think about it is when we ask patients, how are you doing? It's kind of an artificial way to ask when patients come into clinic because they could be having a good day. They could be having a bad day. They're in a contained box where me or PT or somebody is asking them kind of a set of questions that there's a lot of bias in both directions on how to answer. Same thing when we take a mouse and we just watch it run. Like it's stressed something, 1,000 times bigger than it, picked it up, put it in an artificial condition. So the way we studied it in this paper was we were collaborating with neuroscientists, and neuroscientists are much smarter than orthopedic surgeons. And there's this guy named Jarrett Weinrich, who is a gifted neuroscientist who's interested in mechanisms of pain. And he introduced us to this device called Black Box, where you basically can put a mouse close to its natural habitat. Now, it's not outside in the woods, but you can put it into a dark box, which is where mice are most comfortable. And then it basically uses a few different cameras to look and see how it walks around. So we can get this non-biased information on how mice move, which would be like being able to very creepily follow your patient for a week after their appointment and say, well, they said they were really doing well. How well are they doing actually playing pickleball? Or how are they doing moving around? And what we found that was interesting was that the mice with less fat and with more mitochondria, so basically the ones that had more BFR, seemed to move with less pain. And so we can conclude that better muscle is probably correlated with less pain, but we don't know the mechanisms why. And that's more of a correlation and not a causation. So that's kind of our next step is what are the factors that are promoting better recovery? We think that that's at least part the mitochondrial transfer through BFR. And then mechanistically, how could this be causing less pain in patients or mice? And how do we leverage that to make patients do better after any injury or recovery?
It was actually one of my curiosities reading the paper, because there are some studies that have tied kind of pain reduction to ischemic preconditioning type stimuli. And I wondered, perhaps are these mice in less pain? So not only are they getting this BFR stimulus, but after the fact, they're moving around a bit more. So they're getting more of a stimuli from just loading in general.
Yeah. Yeah, it's hard because we know that anything. So, first of all, pain is so subjective. So, we look, the way we look at it is kind of by proxy, by looking at things that we know represent pain in mice, like how fast are they moving? How much are they putting that paw down? How much are they spreading their fingers out? All that assumes that those are going to be good markers for pain. We know they have good and reasonable reproducible histologic markers in the spinal cord and brain for that. But that doesn't always translate into how patients feel pain. And one of the great vexing things is, why is pain so variable from patient 1 to patient 2? But our belief is that if we can make the muscle quality better, and that in turn sends signals, whether it's through better function or through biochemical mediators that suggest that your muscle is okay. So it sends signals to the brain that says you're going to be okay. It doesn't matter why the pain goes down as long as patients feel the perception of less pain.
There was a real bias, maybe almost 100%, towards type 2 fibers with the mitochondrial transfer. Is that just the way the rotator cuff basically anatomically is, or what do you think that is?
Yeah, I think that's hard to extrapolate because we think that the transition to type 2 fibers in a mouse is not necessarily going to be the same as for people because mice, obviously, these were young mice, so they're going to have more type 2 fibers. It makes sense in terms of a growth and regeneration to be preferentially skewed towards mitochondria going to type 2 fibers, or as satellite cells differentiate, becoming type 2 fibers first. But we don't know how that would really translate into an older population with more type 1 fibers in humans. So it's that we think that that's a interesting mechanism, and over time we have been exploring it. That's Michael Davies, the topic of his K award that he's writing now. Whether or not that's something that holds up in people, it's hard because these fibers have the ability to transfer from different fiber types over time. I think of it more as a continuum of the different muscle phenotypes and how much energy they're using, rather than once a type 1 fiber, always a type 1 fiber, once a type 2 fiber, always a type 2 fiber.
And you always just think of fatty infiltration in cuff, in the shoulder, but this FAP story would also play out in the lower extremity and other muscle regions, right?
Yeah, so we had a couple places where we think it's really important. I like to think of it as even Stephen Garcia is one of our residents who went off to do peds and is coming back, did a really nice study that showed, which finally should be published in Science Translational Medicine sometime in the next couple months, which shows that there's a lot of heterogeneity even within FAPs. And then separate from that, and what that means is that even though we see histologically they all look the same, there's probably about 6 to 8 subtypes of FAPs at any given time within any muscle. But also where you are regionally within the body makes a difference. So centrally, meaning rotator cuff, lumbar spine, your hip muscles, we see a lot of fatty infiltration. And the most common place that we see it, actually, in addition to rotator cuff, is patients with low back pain. And when we get MRIs of these patients, we see a lot of different age-related changes, but we see that the paraspinal muscles have a similar degeneration where there's fat within the muscle, a little bit of fat around, but you don't get as much atrophy. When you get more distally, we don't really see that. And we proved that with a mouse model where, for better or for worse, we took a bunch of mice and then just looked at differentiation patterns through kind of the face, body versus extremities. And we found in the extremities, much harder to turn them into fat, but it's much easier to turn it into fibrosis. So we think, for instance, let's say you have recurrent calf strains as an athlete. Well, you may be much more predisposed to get scarring in the muscle for different mechanisms, even though it's the same cell. So there's a predisposition in FAPs in the extremities to turn into scar tissue. Now, should BFR work in a similar mechanism? Yes, because you still have this heterogeneous FAP pool that can still transfer mitochondria. One of the nice things about FAPs is they seem to be in this self-renewal state that there's always an ample supply. So even if you have some that differentiate down a scar tissue pathway, there are others that are still in that resting state or that stem-like state that can be promoting muscle regeneration until you get to the point where the muscle is too small and too scarred.
Right. Very interesting. I love where you're going with all this because, forever the story that people would go with BFR was just simply a muscle hypertrophy and strengthening thing. You just get to these, anaerobic metabolism. But, what I was learning in the DoD from a lot of our really smart muscle phys guys was this hypoxia lever can be really valuable. Your ischemic reperfusion thing. And then if you put the body in some really serious hypoxia just for a short amount of time, there's going to be a lot of things we're probably going to start to discover. And I think this is what's badass. It becomes regenerative more than just like, okay, this is just a strengthening tool. There's a paper that just came out in Cell Metabolism last year. We helped set it up and worked with the group out of Germany and in type 2 diabetics. I mean, it was all about the mitochondria. It doubled mitochondrial content in the muscle and in mitochondrial metabolism was all up. And so the same kind of thing that you're looking at.
Yeah, I think one of the things I think we've learned, I think we're led down the wrong path with a lot of aging studies. And, there's plenty of pundits on the internet and podcasts that say if you look at direct sunlight for 30 minutes, plus drink low caffeine, high caffeine, iced coffee, plus cold plunge, but a lot of what these things are, if you take a little bit away from it, is that a little bit of stress is good for cells. That's going to promote some cells to die when they need to die, some cells to promote regeneration, and some cells to kind of assist other cells to turn over. And that's essentially what we think BFR is. It's this mild ischemia and reperfusion, which is a transient stress to the system. That promotes resilience, whether that's exercise, being scared, eating healthy. All those things are mild stresses. Chronic stress, so that's prolonged ischemia or prolonged muscle injury or overuse, is probably much worse. And we know that there is a very conserved pathway called the integrated stress response that does precisely that. We see a little bit of ischemia, it gets turned on, and it helps with regeneration within tissues. If you get too much of it over and over and over, that's when the wheels kind of fall off and you turn on an entirely different cell pathway. So we think that anything that is kind of a turn on, turn off stress is probably overall good for the body. Now, it doesn't necessarily mean in addition to cold plunges, iced coffee, and direct sunlight every morning, you also need to do BFR every day. But it suggests that these like little things like healthy exercise, even the idea of intermittent fasting, that's a mild stress to the body. As long as you eat enough afterwards to recover, these are all vitally important to help with cell turnover and improve your overall cell metabolism.
Yeah. The hormetic response is real. That's for sure. Damn, I forgot what I was about to ask. It was really important too.
In your study, Dr. Feeley, the mice got around 30 minutes of BFR, I believe. Is that accurate?
Yeah,
it was 10 on, 10 off kind of thing?
Yeah. So, and they were asleep for it. That it's, I've talked to Johnny in the past about we need little automated mouse BFRs.
Working on it. We got rat
Yeah,
ones we found out, but
yeah, it's hard. It's hard to get mice to do anything. We can't get them to exercise. And I think one thing that's really interesting, because we see this in how our athletes use it, is I think even passive BFR may be more beneficial than we first give it credit for. Like the active BFR, like you put the tourniquet on and you exercise, you do squats, you do bicep curls. I think that it is one pathway, but for the people that really can't move yet or are so early in recovery or just trying to recover from, a pitching event or a football game, I think even the passive BFR probably has more utility in that recovery process.
and that's been the rub with rotator cuff repair, with us even trying to set up a study, because we think we need to do things early. But then if you guys do a repair, you're not wanting us to obviously exercise and put stress on the repair. So that's the interesting next maybe piece of a trial would be, could you just do passive BFR post repair to maybe turn on this FAP story?
Yeah. I mean, way back when we did a study looking at uh, pulsed electromagnetic fields, that shell it didn't work. But you could imagine a setup where you get your sling, and with the sling, you get a tourniquet, and part of your recovery in the first 6 weeks is passive BFR. So patients have on their sling plus their extra little sleeve that they just slap on once every other day. And then that's just
Texting Delphi right now.
I love that idea, actually.
Yeah,
I don't know why you couldn't integrate a tourniquet into
that's really
an abduction
badass.
brace or something.
Yeah,
So,
very
yeah,
cool. Well, that's our business. We'll start together, Brian.
there you go.
Um, so just want to kind of wrap this up. Are you looking at a potential clinical trial? Looking at this,
so
or
clinical trials are tough.
mm-hmm.
In 2023, we applied to the NIH for an R61, which is like a grant to set up to do a trial, and they didn't really like it. Their biggest complaint was, does BFR actually work? And then the wheels kind of came off the NIH. So we have held off on any follow up in terms of writing for a follow up proposal. Um, I think one of the challenges, like we've talked a little bit about, is when one of the things that the reviewers, I think, adequately brought up is, how do you measure compliance in this, and how do
Mm-hmm.
you measure efficacy? And then from my standpoint, e- efficacy is pretty easy to show. We have preclinical models, or in the last 3-4 years, your group and others have shown over and over, if patients are compliant with it, it works pretty well. Um, but getting people to consistently wear it is a challenge to get through a clinical trial. So my alternate way to do it is to just try it and see if it works, and
Yeah.
see if we can get patients to feel better. Because one of the things that we've learned with our studies is, we've said over and over, we want to look at fatty infiltration. Well, that's really expensive because we need an MRI. An MRI, even a research MRI, is $500 to $1,000 post-op. So to see a change, we need patients with some fatty infiltration. We need a control group and a non-control group. And then we need to see a change at 6 months and a year. That's going to, all of a sudden be $100,000 worth of studying. But if pain and function are a good surrogate, well, that we can just ask a question for. So
Yeah.
then that becomes a much more feasible study to do. And it's something that's much more reasonable to do, like with company support, and then with a good
Mm-hmm.
physical therapist or a good group of physical therapists to say, yes, Susan wore her BFR. We can track it every time she came in. Plus, she used it 3 times all on her own. And then we have a really good study without the expensive add-ons. And then we certainly don't need to do post biopsies, but we can certainly take tissue at the time and figure out, are there certain people that respond extra well, not so well? Are there people that we really need to target with it? And are there other people that conversely, they're going to get better on their own and we don't need to worry about?
Yeah, that'd be amazing. Well, I think there's going to be some compliance things built into some future
Yeah.
devices, some pretty cool stuff. So that will be there. So just to end it here, as a surgeon, I know I just did your podcast last week, but just your thoughts on BFR, how you've utilized it.
That was exactly what I was going to ask, Johnny. So awesome.
Yeah. So I think there's a variety of different places that we try to use it. And I'm very lucky that I work with great PTs at UCSF, Danny Keller, Krista Prado, who, he's mainly interested in cupping everything to the point where I think Chris is over.
Just got an email for one of his cupping courses.
Yeah, exactly. He's got hair loss up here where I do, where he's been trying.
He does. It's getting thin right there.
But I think we use it mainly in the active phase, but we're starting to transition some patients into that passive early rehab phase. And I think places that we've really, really seen benefit for BFR, I would say the recalcitrant patients with patellofemoral pain that just can't build their quads due to pain inhibition. And, they don't have anything structural, but they need something that will help them build quad and, by proxy, hamstring strength to get over the hump with pain. So their quad is big enough so that they can start doing more advanced things. They just keep hitting that over and over again. And then in that early rehab process with any of our athletes that are trying to return from ACL, I think it makes it the biggest difference is in that 6-week to 3-month. I think that building quad quickly really, really makes a difference, because then when they start into that running phase around 4 months, it's not like they're trying to build quad. They've already built some of it, so they're not feeling unstable with every step. And then with our athletes, I think anybody who's trying to get back onto the field at a high level, it doesn't necessarily accelerate the rehab, but I think it makes your ability to hit that transition when we say return to sports smoother.
Yeah, awesome. Appreciate it, man.
Mm-hmm.
Well, this was a knowledge bomb.
It was great.
I'm excited to see where you go with all this. Definitely going to keep up with the Mito lab. And actually, I think we just registered to be at your conference coming
in
up.
December.
So maybe we can check it all out in December.
Yeah, we'll bring you over to the lab and we'll hook you up to the mouse tourniquets on your toes.
Let's do it, man. Biopsy. I want it all. I want my stuff to glow green.
Yeah. Hopefully by then the Spurs will have a NBA championship, and but we'll see. The Knicks looked pretty good.
I'll bring Wemby out. I'm pretty tight with the Spurs.
That would be amazing.
Yeah.
I'd rather bring Castle and then leave him with the Warriors. I'd be good with that.
Y'all had your run. All right. Thanks, Dr. Feeley. Appreciate your time, man.
Thank you.
All right. Thanks a lot, guys.
All right. See you later.
Bye.
Bye. Thanks for tuning in to the Owens Recovery Science Podcast. Before we go, a quick reminder that the information discussed on this show is for educational purposes only and is not intended as medical advice. Always consult with your healthcare provider before making any changes to your treatment or training regimen. For show notes and additional resources, be sure to check out owensrecoveryscience.com. And don't forget to like the show and subscribe for more evidence-based insights. Until next time, earn your deflate.